Okay, so first of all, thank you to everybody for being here for what's going to be a very exciting talk. I've been looking forward to this. My name is Navraj Sadhu. I'm a psychiatrist practicing in Montreal, Canada. I'm originally from Vancouver on the other side of Canada, the West Coast, and that's where I did all my most of my training. Did my psychiatry training in Toronto, and now I live in Montreal. So I I'm just a general adult psychiatrist. I work here, but I have an interest specifically in psychosis and particularly in psychotherapy for psychosis. So metacognition, acceptance and commitment therapy, mindfulness for psychosis. So it's very much my pleasure to be moderating this talk by Dr. Moncrieff, because it's a topic that's very close to my heart. And so I just want to say thank you to everyone for being here. So I'm just going to go and read a short description to introduce Dr. Moncrieff, and you can. And I also have a question for you, Joanna. I've heard Moncrieff and Moncrieff. Oh, sorry.
Muted. Moncrieff.
Moncrieff. Okay, all right. Okay, so Dr. Moncrieff is a professor of critical and social psychiatry at the University College in London, and also works as a consultant psychiatrist in the NHS in London and in a community mental health team. She has researched and written about the overuse and misrepresentation of psychiatric drugs, and about the history, politics, and philosophy of psychiatry for more generally for several decades now. She's been a leading UK government-funded researcher on reducing and discontinuing antipsychotic drug treatment. That would be known as the RADAR study, and collaborating on a study to support antidepressant discontinuation. In the 1990s, Dr. Moncrieff co-founded the Critical Psychiatry Network to link up with other like-minded psychiatrists. She has written numerous scientific papers and several books, including A Straight-Talking Introduction to Psychiatric Drugs, from PCC Books, and published in September of 2020, as well as The Bitterest Pills, The Troubling Story of Antipsychotic Drugs, which was published in 2013. And finally, The Myth of the Chemical Cure, a book that was published back in 2009. So she's going to be speaking up today. The name of this talk, as you all know, is Busting Myths About Psychosis and Antipsychotics. Okay, so without further ado, I'll pass the mic over to you, Dr. Moncrieff.
Thank you. Thanks for that introduction, and welcome everyone. It's a pleasure and an honour to be speaking to you all tonight, or today, wherever you are. Yes, so I'm going to be trying to bust some myths about psychosis and antipsychotics this evening, and talking a bit more generally about antipsychotics and how we use them, and I hope there'll be plenty of time for discussion as well. So the first myth I want to look at, as Navraj referred to when he was summarising my talk, is this idea that psychosis, or what is sometimes called schizophrenia, is a progressive degenerative brain condition. So this, of course, originates with the ideas of Emil Kraepelin in the late 19th century, who coined the term dementia praecox. And he was essentially characterizing a condition that he had observed to be progressive, to involve progressive deterioration. And anyone who didn't fit that pattern basically didn't have this label of dementia praecox. So it was defined as something that was progressive. But even back then, there were people who had other ideas, such as Eugen Bleuler, another influential psychiatrist who was the first person to coin the term schizophrenia. Bleuler, despite coining that term, which has since become associated with Kraepelin's dementia praecox idea, actually believed that not everyone had a chronic cause, and that many people who had this condition that he called schizophrenia could recover, and some after only a single episode. But Kraepelin's ideas were very influential and really continued throughout most of the 20th century. And when people, and inspired people to look at the brains of people who were in the old psychiatric institutions and who'd been labelled with these conditions. And these studies started to show that people who had a label of schizophrenia seemed to show some differences in their brains from people who didn't have such a label. So here's a typical picture from a Pneumoencephalogram. These were this was a technique where they injected air into the cavities in the brain and then imaged the cavities, imaged the air in the cavities in some way. And what they found was that the cavities in the brain, the ventricles, were slightly larger and the brain matter was slightly smaller in people who were diagnosed with schizophrenia, supposedly. But actually, there were lots of problems with those studies, even though they have subsequently been referred to again and again as showing that people with schizophrenia, and I apologize to this sort of audience for my language, but I will just use this instead of keep saying people diagnosed with or labeled with schizophrenia, but that was the term that was used at that time. So these studies that are quoted as showing that people with schizophrenia had abnormal brains long before there were treatments that might have affected them are not actually as robust as they are thought to be. First of all, the people who were going in for these studies were patients who'd been in the old asylums for many years and who'd had numerous different sorts of treatments that would have affected their brain, including ECT and insulin coma therapy, and lots of drugs, albeit not antipsychotics at that time or prior to the 1950s. Then, moreover, most of these studies actually didn't have a control group, so they were just looking at the brains and thinking, we don't think this is quite normal. In fact, the only comparison I could find with non-patients showed no difference. And there was another study that was done between patients with different diagnoses, which also showed no differences. So these studies do not confirm, as they are sometimes thought to confirm, that people prior to the era of modern treatment had abnormal brains prior to without having received any modern treatments. Then there are studies in the 1980s when CT scans were introduced that also seemed to show that people diagnosed with schizophrenia had different sorts of brains from normal controls. And these studies did involve people who were control subjects who didn't have a psychiatric diagnosis. But they still involve people who were almost all treated with psychiatric drugs on a long-term basis. And in fact, many of the people in these studies had also had ECT or insulin coma therapy or other sorts of treatments. Now, one of these studies by Owens et al., published in 1985, which showed, along with the other studies, that long-term patients with a diagnosis of schizophrenia or manic depression had smaller brains and larger brain cavities than patients who had a diagnosis of a neurotic condition, included 8 people who were not treated with antipsychotics or other modern drugs. And again, this study is therefore quoted as showing definitive evidence that people with schizophrenia have different sorts of brains. They were only 8 people who were not on long-term drug treatment in this study. So really that is far too small a number to show anything at all. Post-mortem studies of people diagnosed with schizophrenia have also been quoted as showing evidence that people with schizophrenia have abnormal brains. These studies, which were reviewed by Harrison in the late 90s, but had mainly been done in the 70s and 80s, again show that people with a diagnosis of schizophrenia had smaller brains and larger brain cavities or ventricles. But again, everyone in these studies had been heavily treated with drugs, including antipsychotics, for many years. Some of these studies, interestingly, find evidence of gliosis in the brainstem and the striatum of people who were taking antipsychotics, and gliosis is often thought to be an indication of some sort of brain damage or injury. So there were lots of confounders in these early imaging studies: drug treatment, other brain-based interventions, people who had a diagnosis of psychosis or schizophrenia, and the normal controls might not have been comparable in terms of IQ or cognitive functioning, and of course they were institutionalized, and therefore their lifestyle and the stimuli they were receiving were impoverished. So that message that people with schizophrenia had different sorts of brains was a strong one throughout the middle period of the 20th century, but there were other people putting forward other points of view. And one interesting study was conducted by Manfred Bleuler, who is the son of Eugen Bleuler, who coined the term schizophrenia. And Manfred Bleuler did a long-term follow-up study of patients who were admitted to a hospital in Switzerland between 1942 and 1943. And it's a shame that this study isn't known more widely, and possibly it's not known because it was written up in a very dense, very long monograph. But he found that 22% of his patients, and this is, of course, is a period that's before any modern drug treatment is available, made a full recovery, and 58% made an initial recovery and then had further episodes interspersed with periods of remission. But maybe the most interesting thing he finds, and he only refers to this qualitatively, he doesn't have statistics or anything to show it, but he comments that those who avoided long-term antipsychotic treatment seem to make a better long-term recovery. So there's someone saying that back in 1974. Other ideas about the outcome of schizophrenia were around in this period. There was a famous book written in 1985 by a psychiatrist called Richard Warner called The Outcome of Schizophrenia, and he looked at the different outcome studies that had been conducted over the course of the 20th century, and he found that outcome depends on lots of things, particularly on how you diagnose the condition, how you assess it, and particularly on the social and economic conditions that pertain at the time that the outcome study is done, so that when there is a buoyant labour market, for example, with a need for workers, the outcome of schizophrenia appears to be better than than at times of economic recession when more people are out of work. He also found that that between 20 and 30% of people seem to be making a full and sustained recovery in studies since the 1920s, and that this proportion did not vary according to the sort of treatment people were having. And although in the mid-period of the 20th century, possibly because of fuller employment levels, recovery improved, towards the end of the 20th century, it actually got worse again. So through the mid part of the 20th century, there were these two ideas going on. There was the idea that schizophrenia was a brain condition, that people had abnormal brains and that this had been shown in imaging studies. But there was also this other idea that, that the outcome of schizophrenia, in fact, could be positive and was more related to social and economic conditions than to interventions on the brain. But then in the 1990s, there's a strong revival of the idea that schizophrenia is a neurodegenerative condition. And this is the language that starts to be used. And it's kicked off by this paper published in 1991 by someone called Richard Wyatt. And this paper really gets the whole early intervention in psychosis movement going. And if you read the paper, it's quite incredible that anyone could really have given it that much credence. It's a review of various outcome studies, and it's not a systematic review. The studies are just selected according to what he feels like citing. And he said, but on the basis of the studies he reviews, he suggests that people who were psychotic for longer had worse outcomes. And therefore, he concludes that psychosis has long-term toxic effects and is a biologically toxic process. And therefore, he concludes that early treatment might be able to avert this process and improve the outcome of psychosis. I've said it's a highly influential paper. Just note the timing as well. So it's published in 1991. The atypical antipsychotics are starting to be licensed in the early 90s and are in development by this time. As I said, it's a non-systematic selective review. There's no quantitative data, just his impressions and summaries of what the different outcome studies show. And sometimes his impressions are really quite misleading. So he says that the Chestnut Lodge study is evidence that early treatment could prevent a poor outcome. The Chestnut Lodge study, Chestnut Lodge was a psychotherapeutic community where people were admitted with psychosis, and it was deliberately set up not to treat people with antipsychotic drugs. Their philosophy was to try and avoid them if possible. And this study actually found that those people with a short duration of prior symptoms had a good outcome, but they had a good outcome despite not having antipsychotic treatment. And those people who had a long duration of prior symptoms had a poor outcome despite having drug treatment. But this idea that schizophrenia or psychosis is a neurodegenerative process became very popular during the 1990s and was picked up particularly by Jeffrey Lieberman and his group in the United States. So he published this, again, influential paper in 1999, in which he suggests that schizophrenia involves a limited neurodegenerative process reflected by the psychotic symptoms that is most active in the early stages of the illness. And again, he was concluding from this that it was important to start drug treatment in particular early on. The main evidence that he's using to base these ideas on consists of imaging evidence from MRI studies that were being done in the 1990s. MRI studies, the MRI technology is able to detect much more subtle changes and differences than previous technologies such as the CT scans. But these studies were also different because they were longitudinal. A number of studies scanned people at one time and then followed them up and scanned them a few years later. And one of these studies was done by someone called Linda Lisi. And in 1997, she published 4-year follow-up results of her cohort, which showed that people who had a first episode of psychosis showed a greater decrease in brain matter compared to a control group over this period of 4 years. And it amounted to that the patients were losing 1.4% of their brain matter per year compared to controls who were losing half that amount. Another study was conducted by a group in the Netherlands, again following up people who had a first episode of psychosis. And they showed that patients had a 2.9% decrease in their brain matter over a period of 1 year, and controls just 1.1%. They also showed that there was a strong correlation between the loss of brain volume and cumulative antipsychotic dose. And other evidence has shown that the treatment with antipsychotics certainly explains some, if not all, of this change in brain volume that is being shown in these longitudinal studies. So this study with macaque monkeys was published in 2007, which really confirmed that antipsychotics cause loss of brain volume. It compared monkeys who were treated with injections of olanzapine, monkeys who were treated with saline injections, followed them up for 18 months and showed that the antipsychotic treated monkeys had lighter brains. Amusingly, or ironically, I should say, because there's nothing amusing about this, this study was supported by Eli Lilly, who thought that they could show that because they also compared the olanzapine with haloperidol, and they thought that they could show that olanzapine helped to prevent an underlying degenerative process better than haloperidol. So they were hoping that that olanzapine would look better than haloperidol in this study, but actually it looked a little bit worse. Then there was a rat study that essentially showed the same thing. Nancy Andreasen's group in the States published their follow-up of first episode patients, their longitudinal scanning follow-up in 2011, and they again showed that there was a correlation between the intensity of antipsychotic treatment and the degree of loss of brain volume in patients across the years that they've been followed up. And they concluded that the study suggests that antipsychotics have a subtle but measurable influence on brain tissue loss over time. And this was a study in Finland that showed the same thing, a correlation between the exposure to antipsychotics and degree of brain volume change. So really the main evidence on which that hypothesis that schizophrenia or psychosis is a neurodegenerative condition has been shown to be false. It has been shown to actually be attributable to drug treatment rather than the underlying condition. Despite this, people are still suggesting that that schizophrenia is a neurodegenerative disorder. This is a quote from Dr. Nasrallah from 2021, again talking about schizophrenia becoming a neurodegenerative condition after onset, with each new psychotic episode leading to further damage. And you'll note that he is making the statement in the context of suggesting that people with schizophrenia should be treated with LAIs, that's long-acting injectables, that's depot antipsychotic injections. And no doubt he is receiving payments from, well, I know he's received payments from lots of pharmaceutical companies, and no doubt some of them are making long-acting injectables at the time that he was saying this. So that's one myth. It's been exposed, but people are still presenting it. The next myth is related to the first one, and this is this idea about the duration of untreated psychosis. It's related to the first idea because untreated psychosis was thought to be part of the degenerative process. Again, it was promoted by Jeffrey Lieberman and his group in the United States. And it really, again, it started with the Richard Wyatt paper, but he didn't actually refer to it as duration of untreated psychosis, whereas Lieberman and co. do start to refer to it in those terms in this paper in 1992. They essentially followed up 70 patients with first episode psychosis, and they found that people who had a longer duration of symptoms prior to their presentation had a worse outcome, and they coined this term, duration of untreated psychosis, which of course in its very nature implies that treatment needs to be started at the first possible time, and that treatment is the key variable in this situation. And again, you can see the link with the ideas about neurodegeneration. They conclude acute psychotic symptoms could reflect an active morbid process, which, if not ameliorated by neuroleptic drug treatment, may result in lasting morbidity. And again, this idea has gone on and on, despite several people raising questions about it. So this is a meta-analysis that's been done recently. I'll show you the second slide first. Actually, this is what the meta-analysis shows about how the duration of untreated psychosis predicts various outcomes. So it predicts negative symptoms, but also positive symptoms, global symptoms, functioning levels, social functioning, vocational functioning, quality of life. Just doesn't predict global cognition. All these things are measured out after a duration of time, after a period of follow-up. At first presentation, duration of untreated psychosis is strongly associated with negative symptoms, but not with other things. And that's just to show that this idea is still very current. This is an editorial from 2022. Now, it was always recognized, this was what I was taught when I was training, that people who had a gradual onset of their condition had a worse outcome, had a higher chance of ending up with chronic symptoms. And it's been shown as well that the duration of untreated psychosis is associated with other indicators of poor prognosis, including early age of onset and bizarre behavior, and of course, negative symptoms, as in this meta-analysis. This meta-analysis doesn't even mention or consider that point, that idea that actually maybe there's something intrinsic about a slow and gradual onset that predicts a worse outcome. Let's put it the other way. People who have a short, an acute onset, sometimes maybe in response to a traumatic life event, are often the people who do better. And I'm using very, we should, I think it's really important to remember with any mental health condition, the variation of outcomes is huge. And just because someone has a gradual onset doesn't mean that they will inevitably have a worse outcome. But taken as a group, they are more likely to. So I went back to the textbook that I studied from when I was doing my exams, and this is what it says. There is firm agreement on the characteristics of the initial illness predicting, it's not meant to be God, sorry, good or bad outcome. And those that predict good outcome are acute onset and a stressful event or situation at the time of onset. Now, of course, the duration of untreated psychosis and the idea that schizophrenia or psychosis are neurodegenerative conditions are the justifications for the early intervention in psychosis movement. Other justifications, which I would like to put out there, I think are very reasonable justifications, are the burden that these conditions often put on families and the desire for earlier help. It was recognized that it was often proving very difficult for families to get help in a situation where a family member was developing or potentially developing a psychotic episode. But as I said, the other inspirations for this movement were this theory that schizophrenia is neurotoxic and that antipsychotic treatment is protective. And that it should be started as early as possible to reduce this duration of untreated psychosis. So what is the evidence that early intervention affects outcome, particularly early intervention, particularly starting antipsychotics early? Well, there are several studies that have looked at early intervention, patients who've been through early intervention services and that have randomized people to either have early intervention or standard services. And this is a recent systematic review of these. And they all show that patients who are under early intervention services do better than patients who are not while they are under the service. But none of them, and these are some examples of this. There was the Danish OPUS study, the Leo study in London, and then a recent study that's been done in Hong Kong. But none of these studies have shown a difference in people further down the line after the early intervention service has stopped. In fact, only one has done a long-term follow-up. That was a 3-year follow-up done of the Danish OPUS cohort, and they found that at 3 years after the early intervention program had finished, there was no difference between people who'd had the early intervention and standard care. But there was also actually no difference in drug treatment between the groups anyway. In fact, there haven't been any clear indications that early intervention studies start people on drug treatment any earlier or use any more drug treatment. And I would say that my experience recently is that early intervention services are actually aiming to try and minimize antipsychotic drug treatment. So there's no randomized controlled trial evidence of that early intervention services have long-term effects on outcome. This is a 10-year outcome study of an early intervention service where they compared people with matched controls. So it wasn't randomized, but they did try and find a matched control service. And this did show some benefits in terms of a longer duration of employment and lower suicides, but not in terms of symptoms or global functioning. So that's early intervention and duration of untreated psychosis. The next myth I want to look at is the dopamine hypothesis of schizophrenia. Dopamine was discovered by a Danish psychiatrist called Arvid Carlsson, or is he Swedish? He might be Swedish, I'm sorry, in 1963. And he discovered its role in Parkinson's disease. Later in the 1960s, it was suggested that dopamine overactivity might be the basis of schizophrenia. And it was suggested on the basis of experiments with cats that showed that haloperidol, which at that time was being used for the treatment of schizophrenia, blocked dopamine receptors. So it was proposed that schizophrenia might be a condition that was the opposite of the effects of the drugs that were being used to treat it. However, it was not immediately embraced. It was clear that there was a lot of contradictory evidence and not that much supportive evidence. In the mid-70s, it's described as not the only possible interpretation of the data and not even the most plausible by a leading psychiatrist and researcher. And by 1976, the evidence is described as compelling but not irrefutable. So I did a review of the dopamine hypothesis, which is a bit old now and needs updating, and I can't give you a systematic update, but I can give you a little bit of an update. Of course, one of the main planks of evidence for the dopamine hypothesis is the idea that antipsychotics are an effective treatment for psychosis and that they target the dopamine system. But actually, reviews of antipsychotics show that dopamine is probably not essential to the action of all antipsychotics, although it's undoubtedly central to the action of some of them. So this review done in 2012 showed that D2 occupancy, the dopamine 2 receptor, is thought to be the key receptor and is the target of most antipsychotics. So it showed that high D2 occupancy was correlated with reduction in symptoms for most antipsychotics, but not for clozapine or quetiapine. Clozapine obviously being, is a drug that's thought to be one of, if not the most effective antipsychotics. But actually, the paper didn't even find an association when quetiapine and clozapine were excluded until an outlier study was excluded. So this does not demonstrate that, that drug treatment is consistently working by altering the dopamine system. The other thing that was thought to support the dopamine hypothesis was the fact that stimulant drugs like cocaine and amphetamines can induce psychosis, which of course they can. So it is possible to induce a psychosis chemically. But in fact, this has never been pinned down to dopamine. And when people were investigating the neurochemical basis of stimulant-induced psychosis, they were also looking at noradrenaline, which was thought by many to be a stronger candidate for causing the psychosis. Direct measures of dopamine and measures of dopamine receptors have been negative or have shown changes that are clearly related to the effects of antipsychotic drugs in the case of dopamine receptors. But there have been a number of indirect measures of dopamine activity, measures of the uptake of L-DOPA, which is thought to be a measure of dopamine synthesis, and a measure of dopamine release in people who are given amphetamines, which are claimed to provide some evidence that dopamine activity is increased in people who are acutely psychotic mostly. Actually, these studies are inconsistent, but one of the main problems is that they are confounded by stress and arousal and movement. People who are acutely psychotic are more likely to be stressed, more likely to be highly aroused, and possibly to be agitated and moving around a lot. And all these things are known to be associated with dopamine, with higher dopamine activity. But actually, some recent studies of dopamine synthesis are in fact negative. This study by Kathagen et al. In 2020 is reported to be negative, and there's a study by Jahar in 2018, which is presumably negative, although not reported to be so, but they looked at dopamine synthesis between patients and controls, and they don't report a difference. And this is just to show you how antipsychotics affect the dopamine system very differently. So some certainly do have profound effects on dopamine, particularly the D2 receptor, such as haloperidol, but others have much less profound effects on dopamine and affect many other neurotransmitters. Nevertheless, the dopamine theory persists, and these are quotes from health websites talking about it, and it's still widely researched and widely quoted in textbooks and academic publications. So myth 4, this is the idea that antipsychotics target the biological basis of schizophrenia or psychosis. And for those of you who've seen me speak before, this is the myth that I have called the disease-centered model of drug action. This idea is the idea that drugs work, drugs like antipsychotics, but also antidepressants, all drugs in mental disorders work by having a normalizing effect, or a selective anti-schizophrenic action, as Solomon Snyder put it. This is the idea that has been very widely disseminated by the pharmaceutical industry and put across as the idea that there is a chemical imbalance that can be rectified by drugs. I think this quote from Eli Lilly's Zyprexa website shows why this idea is so useful. Antipsychotic medicines are believed to work by balancing the chemicals found naturally in the brain. It makes olanzapine, which is a drug that makes people put on vast amounts of weight and seriously disturbs people's metabolic function, sound as if it's homeopathic, as if it's a natural treatment that doesn't change the body in any significant way. So this way of thinking about drug action that I could call the disease-centered model is the current mainstream view that drugs work by targeting and correcting an underlying abnormality. And the abnormality is often proposed to be one of neurotransmitters like dopamine, but could be other sorts of abnormalities. But there's no evidence that any class of psychiatric drugs works in this way. And that's because we don't know the mechanisms underlying any disorder or even any group of symptoms. And placebo-controlled trials, which might show a difference, might show that a drug is more effective at reducing symptoms than a placebo, do not confirm that drugs are working in this way. Other evidence that the drugs might have mechanism targeting effects is lacking. But most importantly, there are other ways of explaining drug action. So this is my idea of the two models of drug action, the disease-centered model, this idea that drugs work by correcting an abnormal brain state, and the drug-centered model, the idea that they're not far from correcting an abnormal brain state, they are creating an abnormal or altered state of the brain, and as a consequence, an altered mental state. And that it's these alterations, when superimposed onto underlying symptoms, that may be perceived as an improvement, or experienced, or genuinely experienced as an improvement. So this is a model that highlights the fact that psychiatric drugs are psychoactive substances that produce alterations because they affect the brain. They produce alterations in mental states, in sensations, cognitions, emotions, and behavior. But they also have linked physical alterations. If you think of a drug like a benzodiazepine, like Valium, it produces a sedation which is both mental and physical. And it's these changes that the important thing is that these drug-induced changes are changes to the normal state of the body and the brain. And they're changes that will occur in anyone, regardless of whether or not they have a diagnosis of a mental health problem. So how does this work out with antipsychotics? And why does this show that the disease-centered model is not valid? So we know a little bit about the drug-induced effects of antipsychotics because in the early days when they were used, people actually did have, the psychiatrists using them actually did have a drug-centered view of their action. And so they were interested in the sort of changes that they produced to normal mental functioning in a way that later psychiatrists lost interest in. Because later psychiatrists just became convinced they worked in a disease-centered way and stopped wanting to understand the sort of alterations they produce. But these early studies showed that antipsychotics are sedative substances. They come from a whole load of different sorts of classes, so they have different sorts of effects, but by and large, they're sedative substances that reduce movement, attention and reaction times, and all basically impair or slow up all other cognitive activities. Subjectively, they produce feelings of sedation and, importantly, emotional flattening and reduction in initiative and motivation. And these are the sorts of descriptions that people give of taking them: feelings of mental and physical stagnance, feeling emotionally empty, and feelings of lethargy and indifference. This is one of the French psychiatrists who first used antipsychotics, Pierre Denica. And he, as I say, had a drug-centered view of their action and proposed that they worked because they produced a mild form of Parkinson's disease, which basically replaced the underlying psychotic symptoms, or suppressed them. And the key, he felt, was the emotional suppression or indifference that they produced. So he felt that although people often still had delusional beliefs or hallucinatory experiences, these became less intense and less preoccupying. And he said patients simply lose interest in their delusions. And in fact, quite a lot of people at this time were describing the effects of antipsychotics in this way. So I think if you look at them like that, you can easily see that they might be effective in suppressing psychotic symptoms, but they're also likely to be quite unpleasant to take and maybe to make you worse in the long run, especially if your psychosis has actually just cleared up naturally anyway. I think the dilemma is really well summarized in this cartoon by someone who calls herself Anti-Psychiatry. And she's showing the choice here between the sort of colorful but dangerous temptations of madness and the rather gray normality that is induced by taking antipsychotics. So, and that's just what I've said already. So basically this way of this drug-centered model provides an alternative explanation for what antipsychotics do in psychosis, and shows that the disease-centered model is not evidence-based. I just wanted to finish by just thinking about what this means in bipolar disorder, because I've talked a lot about what it might mean in psychosis and schizophrenia, but not so much about bipolar disorder. And then, so I'll say a few words about this and then I'll finish. First of all, what is bipolar disorder? I think we need to clarify this because the word, the concept has been changed recently. So the classical idea used to be, the classical concept used to be called manic depression, and was a condition where people had episodes where they became very disturbed, very manic, almost always needed to be hospitalized. And then some would then have a depression following that. Some would have a depression that wasn't related to that. And some didn't have any depressions at all. But the thing that was really characteristic were these very distinctive episodes of very florid mania. Then there came an idea that maybe there were some people who had slightly less distinctive episodes of mania and mainly had depression, and that was called bipolar II disorder. Then there was the idea that maybe there was a spectrum and there were people who had sort of more regular ups and downs or mood instability. And linked to that was the idea that there might be, that bipolar disorder might exist in children and manifest as behavioral difficulties and temper tantrums, etc. So as you can imagine, with this sort of gradual expansion and increasing vagueness of the concept, the proportion of people pulled into the bipolar net got larger and larger. So in the 20th century, David Healy's study showed that in the early 20th century, showed that classical bipolar disorder or manic depression affects less than 1 in 1,000 people. Then Angst, this group from Switzerland, suggested that 5% of people have bipolar disorder. 5% of people have bipolar 1, have the classic manic depression, and another 11% have bipolar 2. And then he suggested a bit later that maybe 24% in total have the whole spectrum of bipolar disorder. And if you look at the sort of tests that have been around for bipolar disorder and the sort of symptoms they ask, it looks as if almost anyone could fit themselves into this diagnosis according to these tests. Because they ask things like, does your self-confidence range from great self-doubt to equally great overconfidence? Are there great variations in the quantity and quality of work you produce, etc.? And of course, these sort of tests were produced by the pharmaceutical industry. This expansion in the concept of bipolar disorder was happening at a time when the atypical antipsychotics were around, when they'd already replaced the older antipsychotics for the treatment of people with psychosis and schizophrenia, diagnosis of psychosis and schizophrenia. The drug companies were looking for a new market, essentially. And here we have an advertisement emphasizing this idea that bipolar disorder means mood swings. So what might drugs do in bipolar disorder? Well, the first thing to say is that there really is no such thing as a mood stabilizer. And this is a very misleading concept, another myth. The concept was established by Abbott Laboratories to market Depakote, the anti-epileptic drug, to people with bipolar disorder in the 1990s. All drugs that are referred to as mood stabilizers are sedative agents, and none of them have been shown to reduce mood fluctuations, not even lithium, which has been trialed in volunteers in fairly detailed ways that others haven't. And these studies did not show that it reduced mood fluctuations. What do they show? Well, not surprisingly, as they're all sedative drugs, they do reduce the symptoms of mania. And there is evidence that if you continue a mood stabilizer, once you're established on it, you are less likely to relapse, especially into mania, than if you discontinue it, if you have a diagnosis of classical manic depression or bipolar 1. But there's a significant discontinuation effect. So this is an example of a discontinuation effect. This was a trial where people were randomized to treatment with olanzapine or placebo for acute mania, and then they were randomized into a long-term follow-up study. Then the people on olanzapine were just on olanzapine who'd been treated for mania were randomized to placebo or olanzapine for a follow-up study. And as you can see, the probability of relapsing into mania was much higher for those people who were randomized to placebo, but it all occurs early on. It's not as if, it doesn't look here as if there's a natural process of relapse going on. It looks as if there's something happening that is related to the discontinuation of the drug. And in fact, there are several studies in bipolar disorder that show that your chance of having a relapse after you stop lithium is higher than your chance of having a relapse before you ever started it in the first place. So there's something about stopping it that predicts relapse. So the question, I think, from a drug-centered perspective about the use of drugs for bipolar disorder is this: does a possible reduction in the risk of relapse that may not exist because of the discontinuation effect justify the continuous use of toxic and debilitating drugs in a condition in which people do get better anyway? I'm not saying that everyone should always say no. I can understand that acute mania may be a very frightening thing, and people may want to take whatever chance they have of reducing the risk of having another episode. But I think it's really important that people know what they're doing and are not misled into believing that this mood stabilizer is somehow going to stabilize some underlying biological abnormality that's going on. It's not. It's a sedative drug that may, due to its sedative effects, prevent episodes of mania in particular. There's almost no research in people who have other types of bipolar disorder. And although it's widely claimed that lithium prevents suicide, this is not supported by evidence.
Thank you very much, Dr. Moncrieff. That was a very interesting presentation. Lots of interesting points that I did not know. So, yeah, we do have a lot of questions here actually gathering here, and I'll just go through some of them and try to get it through as much as we can. And I apologize if I don't get to your question. One here says that if a person has been taking antipsychotics for a long time, in this case since 1982, in your opinion, will they be able to get off them?
I don't know is the answer. I don't know. I think it will be difficult, but I would never like to say never. And you know, people are so varied in their response to things. That's, yeah, I think it's just very difficult to say. And I suppose my advice would be just to go very slowly and try and reduce them. You know, I always say to people, if you can get the dose down, that's going to be helpful. That's going to be good for your body. You're going to reduce all the physical complications you get with antipsychotics. So, you know, just try and reduce and maybe, just take it as it goes.
This actually makes me think about one of the reasons that in the long term, when after I see somebody who has had the psychosis, there's a tendency your psychosis is treated, you're on a medication. Often the practice is like whatever dose was used to stabilize at the hospital, it just continues. And sometimes people think, okay, well, it's been a while now, maybe we could try to come down and so that they have a longer dose in the long term, and maybe even to potentially to even come off the medication. But sometimes when once you're treated in the system in psychiatric services, eventually when you're stable, you go back to a family doctor here, which you can do. And family doctors tend not to touch, for good reason. I mean, if I were a family doctor, I wouldn't be touching somebody's antipsychotic. So it could be like, 15 years after a person has had one episode that they're still on the same dose, and had somebody gone in and tried slowly, could have even been like just half a milligram per every 3 months that you go down, but over 6 years that would have been significantly reduction. So it makes me think about one of the reasons that I really do try to have a goal of coming down with medications.
Yeah. I mean, my feeling is that particularly after first episodes or second episodes or third episodes, early on, people should have treatment for their episode if they want it. I should say that there's been people can get over a psychotic episode without medication. And there's been an excellent study in Australia, just a pilot study, which showed that it was a placebo-controlled trial and showed that people who in the placebo group didn't actually do worse than people in the antipsychotic group. And these were people who were acutely psychotic. They all had very good psychosocial support, which I think is key. So not everyone necessarily needs antipsychotics for their acute episode, but if you do, and I think they can be helpful in that situation, I do, then I think people ought to have the chance to come off them once they are stable. And I don't think we should be keeping people on for 1 year or 2 years just because the guidelines say so, right. Because the guidelines are all based on those discontinuation studies. So I think we should be trying to take people off as soon as they're stable, and just do it slowly and sensibly, and get people off if we can. And then if they have another episode, you treat the next acute episode, and again, you try and take them off afterwards. Because I think that we should be trying to minimize the number of people who end up on years and years and years of medication, because probably it is more difficult to get off if you've been on antipsychotics for many years.
For sure. And just add one little point, I feel like if the effectiveness, if you do have a relapse and if you've already been on a high dose, then now you have to go on a higher dose, whereas opposed if you had come down, then a small dose in the future might be more effective for you. Yeah,
exactly.
I
have people who come out of hospital, like you say, on very high doses, and if they get left on those doses, where do they go next time? If they have a problem in the future, then they just, and this is what happens, isn't it? The dose just gets upped and upped and up because no one reduces it.
Add a second one.
Every time there's a problem, they put the dose up. Yeah.
Right. Okay, so another question here is, your presentation suggests to me that the promotion of antipsychotics is less evidence-based than assumed in clinical practice. This is an important message to physicians. What do you think allied health professionals, for those not prescribing medications, can or should do to improve the status quo? And I was wondering about this too, in your practice where you work, right? What is the environment I know that where I work is, I'll have sort of a care manager telling a patient that, it's just like diabetes, just like taking a medication for diabetes. Now, maybe not always like that. So what do you think about that?
That's really difficult. I mean, all of us here need to be, to as much as we can, trying to educate the people around us, which includes staff if we're professionals, includes other members of staff. But that can be hard, and it's not always easy to go in and say everything you ever knew is wrong.
Yeah.
So I don't do it like that, but I think you can sort of over time create a culture where people are more questioning and less rigid in their approaches, and I mean, if you're an allied health professional, I think just always try and identify the other professionals who share your points of view and try to get together and see what you can do. There may be psychiatrists in your service who agree with you and who would be enormously grateful for your support, because actually, as a prescribing psychiatrist, you probably have the same. You can feel very lonely, can't you? And if there's someone else saying, yeah, I think it's reasonable to reduce his medication, that's really empowering for a psychiatrist. So.
Yeah, actually, when I first started, after I finished my residency, I went to Vancouver to work, moved back to Vancouver to work. And I thought that, yeah, these ideas would be completely different. And one of the first psychiatrists I worked with was somebody who's from England who happened to work with you. So we also shared this idea of like, let's try to.
I know who you mean. Yes,
yeah.
That's the name.
Yeah. Yeah.
So yes, Richie.
It's Richie. Yeah. Okay. So I was surprised, like, wait, what? you worked with her? So here in Montreal, there's a critical psychiatry conference that happens like pretty every year, and the University of Toronto residents now they have like this a sub in clinical interest group among the residents in this topic, which when I was in residency that wasn't the case. So yeah, so I do see that there's some movement there. So is there permanent brain damage associated with long-term antipsychotic treatment other than tardive dyskinesia, but related more to like cognitive abilities?
So the question of whether antipsychotics affect cognitive abilities is fraught. And people have argued it both ways. So there are a lot of people who would suggest that antipsychotics, or were suggesting that antipsychotics improve cognitive functioning. And they were saying that back in the 80s. And then funnily enough, when the atypicals came along, everyone admitted, oh no, the older antipsychotics made cognitive functioning worse, but the atypicals will make it better. But most of these studies have just involved following people up who are on treatment, and their test results get better, and it's concluded that the antipsychotics are helping improve their cognitive function. There are two reasons why that's wrong. One is that a lot of these people are symptomatic, and it may be that by reducing the symptoms, or because the symptoms have reduced over time, their cognitive function improves. But secondly, people get better at doing tests. So there are practice effects, they're called. And so it's recognized that actually follow-up tests, people always improve anyway. So there have been people suggesting that antipsychotics improve cognitive function. There are some studies that suggest that antipsychotics make cognitive functioning worse. Tardive dyskinesia actually involves some cognitive deterioration. That is something that has not been widely publicized or recognized. And it's not surprising. If you have a degree of brain damage that's actually producing abnormal involuntary movements, it's very likely that you have brain damage that's going to affect your cognitive functioning, because it's quite extreme to be having abnormal involuntary movements. And indeed, studies that have followed people up as they develop tardive dyskinesia have shown that their cognitive functioning gets worse in tandem with them developing the abnormal involuntary movements. So tardive dyskinesia is almost certainly not just about involuntary movements, but also about cognitive functioning. And maybe the good news is that tardive dyskinesia does, in many people, get better with time, but it can take years and years and years, and some people it probably doesn't ever get better, but it certainly does in quite a lot of people. And I would say even years after people have stopped, that tardive dyskinesia can improve. So maybe that's a bit of good news actually for effects on cognitive functioning.
Mm-hmm. Okay. Thank you. So another question. So there's about 42 questions. So I'll try to get to a couple of them before we end. I'd be really interested in hearing what Joanna understands as the causes of psychosis and what treatments she would recommend. So a very general question.
Oh gosh, yes. So the causes of psychosis. Well, so I think psychosis is, I like the phrase that was used by Alec Jenner, who was a British psychiatrist who was associated with R.D. Laing, was a friend of R.D. Laing's. And Alec Jenner called psychosis or schizophrenia a way of being human. And I think that puts it nicely. And that suggests that it is a way that some human beings are, a way that some human beings deal with the sort of stresses and strains that life throws at them. And in that sense, it's not really a thing and it can't really have a cause. But what makes people react in that way? Trauma, things, adverse life events. It's undoubtedly the case that, if you've suffered sexual abuse or, severe trauma as a child, your risk of having some sort of psychotic condition is very much higher than if you did, if you had a very stable upbringing. But I don't think that's the case in absolutely everyone. I think there are some people who don't have really, who haven't had particularly traumatic experiences, but nevertheless do seem to react to fairly normal stresses in their lives in this way. And as I say, I think it's just a way of being human. And so how do we treat it? We support people. And I think someone said to me recently that we shouldn't be, talking of treatment is wrong. We should be talking of support and helping people. And how do you support people who react in this way? Well, you try and gently bring them out of it. And sometimes, I think it's okay to use drugs, as I said, if someone's really, really completely preoccupied with an internal world and clearly very distressed by it and just not functioning. But the Soteria project in California, where the therapeutic community, where they tried to avoid the use of antipsychotics, I think shows that, a sort of non-intrusive form of therapy, of being present with people, of support, can help some people to come out of it or come out of it safely. Maybe they would have come out of it anyway, but what we want to make sure is that people are supported so that, they get through safely and don't do any damage to themselves or other people.
Right, and I think that actually touches on some of the other questions that people were talking about what are some other approaches that people can use, and you mentioned the word trauma, so I think that I'm glad you brought that up too. I think that in my experience with people, our diagnosis, the one that we're supposed to be using is sort of like the check boxes where it doesn't really ask ask people what happened or what they went through, and I consistently with the people that I meet who goes through once you get through to their story of the things leading up to things, there's always some sort of trauma, stress, conflict, overwhelming circumstances in which it made sense for them to start thinking that way. If you were in their shoes, you probably would have started thinking and perceiving things in that way too, which might be problematic. There were a lot of, maybe they jump to the wrong conclusions. Their thoughts about what's going on in another person's mind were not quite accurate. But you can sort of understand the story of how it developed a bit better. Yeah.
I see someone in the chat was talking about how their bipolar disorder was a spiritual awakening, and and I think that can be, I think psychosis or mania can give people spiritual or other sorts of insights into life on occasion, and so I think there's also probably a role for helping people to process what's happened to them afterwards, or at a time when they're able to do that anyway, in order to integrate the experience into their lives, and if possible see if there was anything that was positive that has come out of it.
Right. Okay, another question here is hi Joanna, and great talk. When you say that a person could try to slowly come off once stable, what would you say is stable? So what if the person still has voices and delusional thoughts? Are the voices and delusional thoughts likely to go in time if the person comes off slowly and carefully?
I mean, I suppose it depends, whether the antipsychotic is helping in that situation. If you reduce the antipsychotic and the delusions and hallucinations get a lot worse and the person can't function, then it's not a good time to reduce. If you reduce it and it doesn't make any difference, then maybe it's not working, as they often don't work. So I think, you have to suck it and see, really. I think it's going to be different in different people, and difficult to say from any one individual what the case will be.
Right. So yeah, it depends on what the circumstances are. And the idea I think that really resonated when you talk about how it's you're treating maybe the symptoms on the surface, but we should really move away from thinking that we're actually correcting it. And for example, in diabetes, I think you were talking about this at one point. Even giving insulin to a diabetic is not correcting the underlying. Actually, doing exercise and diet, if you are something that actually does start improving your insulin functioning on a natural basis. So with people, when you're coming off of the medications, what I do is often for people who are amenable to sort of talking about their symptoms, is that we come down the medications and actually kind of wait for some symptoms to come back at a level that they're not so intense that they're overwhelming, but they're present and workable with.
Yeah, that sounds really sensible. Another thing that I think is a big issue with people coming off antipsychotics is the emotional rebound that people get. So these drugs have been really squashing your emotions down, and if you've been taking them for a number of years, you really haven't been experiencing normal emotions for a long time, and then you take the drugs away, and you'll probably then get like when you hold a spring down or a ball down, you probably get a rebound. You probably experience emotions that are even more intense than you would have normally, because they've been squashed down for such a long time. And people can really find that difficult, and it can and I think that sometimes is what is diagnosed as a relapse, or sometimes it can sort of blend into a relapse because people are so sort of agitated and hyper alert and anxious that they become paranoid. So I think the emotional consequences of reducing antipsychotics are really significant, and we have to be really aware of them and put a lot of support in to help people manage them, to help people recognize what they are, first of all, and help people manage and get through them.
So let's hear, there's a liability problem for prescribers. Since psychopharm is the standard of care, at least in the US, then if they are not prescribed, then something bad happens, the prescriber could be in trouble. So this is something that I've thought a lot about too.
Yes. Yeah, and I mean, all professionals have to think in this way. So I just think it's a case of justifying what you do very carefully, which is a combination of looking at the evidence and talking to the individual and finding out what they want, and and whether taking an antipsychotic, for example, is making their life better or worse. If they're so drugged up and sedated by it, that it's really not helping them, that seems to me to be a very good justification for reducing someone's medication. Now, if that person has done something really dangerous when they were psychotic, that is a consideration. It has to be a consideration. You might then want to reduce the medication more slowly, or not go down to zero or something like that. But it's still a conversation that you can have and that you ought to have, I would say.
Right. I think that what I really try to do is sort of like you're saying, is to document the rationale for everything, and that what you're doing when you're not giving medication, what else are you doing? All this stuff. We're not just taking something away. We're taking something away, but also doing a lot of therapy and education about the symptoms, about the psychology of what your mind is going through, and how to recognize relapse, and also to talk about and document the the benefits that you've seen. So as you come down from medications, you might notice that a person starts making a bit more interpretations and about their environment, starts thinking that maybe people's talking about them, but we were able to discuss it, and now they're starting to realize that maybe I'm just jumping to conclusions. So to document that, now they have a better understanding of when they're jumping to conclusions compared to before.
Yeah.
Sorry, I'm trying to a lot of questions, a lot of good questions. And I don't know if how do you feel that this can be translated to the community mental health setting? So uninsured or underinsured Medicare homeless populations that often bounce back and forth from me in the inpatient setting. So social workers, therapy, and case managers are few and far between. And then I have minimal time with patients for education, and often I have only meds to offer them as a prescriber. And how do I help my patients rehab and keep them out of the hospital? And this is also a thing that the busier that I am and the more chaotic things are, the more I'm like, yeah, okay, all I have time for right now is medications. And coming down on your medications means that I want to see you more often and be more involved, and I don't have the time to do this. So yeah, so that can be sometimes a challenge too.
Well, I think, I mean, we want to keep people out of hospital because it's not very nice in hospital nowadays, and because it's expensive. But in principle, I don't think that the idea of somewhere where you go when you're having, an episode or a deterioration is necessarily a bad thing. And I think we could design therapeutic communities that were more therapeutic and more supportive for people. And then we wouldn't feel that we have to keep people drugged up, at all costs to ensure that they don't go back to hospital. And actually, that seems wrong to me.
Right. Yeah. I'm using one of the things that sticks out to me in a question is what we use as a measure of like the outcome measure. So often it's hospitalizations. Is that really a number of hospitalizations? Is that really a measure of how well sometimes people who are doing the best are the ones who've been to the hospital 3 times this year, and the ones who have not been are the ones that are the most disconnected from everybody else. So
absolutely. You could be sitting in your bedroom doing absolutely nothing, for years on end, or you could be going into hospital in and out, and in between time going to work full time, couldn't you?
Exactly. Yeah.
So no, completely.
All right. So we have about 7 minutes left. How do we shift society from an individual to a socially oriented society to promote psychosocial supports and treatments? This makes me think of some of the research out there, the ideas about the outcomes of psychosis in more individualistic societies like ours and more collectivist societies.
Yes. Yes. There's a great book called Crazy Like Us by Ethan Waters. Do you know it? Yes.
Yeah, I read it, yeah.
And the chapter in that about the family in Africa with a young girl who has what we would call schizophrenia or psychosis of some sort is really enlightening, I think, and how she's integrated into the whole community, into the extended family and the whole community, and how she has a role, so that there are things for her to do when she's well, but also the possibility of her withdrawing a bit when she's not so well. So yes, it's really important that we try and create societies and communities where people can have a role and can contribute, and are not just excluded and separated into the mental health system. How do we do that?
Complicated.
Yes. I guess by doing all the little things we do, we do, keeping on doing all the little things we do.
Maybe like in the future, the modern, I guess this is the modern model of we call those cultures more traditional cultures, the more collectivist ones. But who knows, maybe in the future, we're going to start seeing a wave of people becoming more community-based and intergenerational again, where you live in communities with your grandparents or whatever. Societal shifts.
Yeah, we do. There is a problem with communities, especially in big urban conglomerations. I think maybe it's easier in smaller towns or villages, but there are many people just living very isolated in the middle of cities, and somehow we need to do something about that. I think there are all sorts of ways we could tackle that. We could redesign housing so that every housing has a communal area, for example. Right. Or we could, have the council employ someone to do communal activities. In France, the local councils employed someone whose job was to organize dances for older people. Well, you could do that for everyone. Right. So, I think just some basic communal activities would be so helpful.
Yeah, I agree.
Put everyone together.
Yeah, there's some creative ideas, like you just mentioned, that where it's more than one people benefiting mutually from that interaction.
And of course, we've, religious organizations used to do that and still do that for some sections of society, but not for everyone. And, we really need something to replace the social role that religions played for many centuries, I believe.
Okay, we're 27. Maybe I'll just take like a couple more questions. And what are treatment options you found more useful for psychosis and supported by evidence? I guess it's similar to a question before, but if there's anything else you want to add to that. I'm just picking randomly now.
Not really.
I personally, I find that one of the types of intervention that I found the most useful and rewarding is really that sort of metacognitive discussions and built on helping people build more insight into the psychology of what's happening to them in the moment. And,
So some people really respond well to that, don't they? Some people struggle with it, but yeah.
Oh yeah. It's and I think that's what really, where it's not a one size fits all. It's different people have different sort of needs. Okay. Could you, Mirina Frank, psychologist, what about the differential diagnosis of dissociative disorders? That's a topic that I don't know personally that much about. If you,
I think that's another topic for another day.
Right? Yeah, probably. Yeah. Okay. In any case, I think we're probably coming to the end of our talk here. It's about to be 2 minutes to 2:30. So I just wanted to thank you so much for taking the time out of your what I imagine is a busy schedule up there in England, and to give us this talk. It's a very important topic. I think the fact that we have these many, 700 people or whatever that are joining us today is a testament to how important this is and how needed this work is in this field. So
Thank you for everyone's questions. Sorry I didn't get around to all of them, and I have been glancing at some of the comments in the chat, which are really interesting. It would be great to be able to carry on chatting more, but unfortunately I have to go and have my dinner. Thank you everyone for coming and all your comments you've made.
Yeah, thank you. Yeah, thank you for all the comments. Lots of interest, lots of participation, and and thank you very much, and bon appétit.
Thank you.